Okay, so today I'm going to be talking, really discussing the role of hematopoietic stem cell transplant in sickle cell disease. Just some nomenclature. The field has really kind of moved away from saying bone marrow transplant, just because the stem cell sources can come from different places. And so the preferred term, and you may hear this now in the community, is hematopoietic stem cell transplant. And so that's just a little update there. But really what I wanted to discuss with the group today was just kind of an overview of what transplant entails, because I think a lot of times there's some misnomers about what it is, and obviously there are some risks associated with the transplant, as well as a lot of times when I meet with families, they just don't understand the eligibility, like who is eligible to go forward with transplant. We'll go over some of the benefits and the outcomes, and then I'm going to describe some of the current treatment advancements in transplant, as well as some advancements in gene therapy. So I think you probably have seen this, chart before, or at least come across it because you're well versed in sickle cell disease as a disease in the U.S. But I think it is really important to note that it is the most common genetic disorder in this country, in the US. And so, it obviously affects African Americans more than other ethnic groups, but we do see a fair proportion of Hispanics who also have sickle cell disease. I think what's devastating about the disease is the toll that it has on a patient's life, and how their life is impacted from a quality standpoint. And especially since I'm a pediatrician by training, the effect that it has on young children's lives, and then as they grow older. And so one of the major things that we worry about as pediatricians is really that risk of stroke that can happen in young adults, in pediatric patients. And we know that about 11% of patients in the group that I see will develop a stroke by the time they're 18. And so there's been, updated studies kind of looking at the life expectancy for sickle cell disease patients. And depending on the type of sickle cell disease you have, it's approximately about 48 to 55 years of age, which is significantly lower than the national average. So we need to try to work on ways to improve this life expectancy in this group. So I thought this was kind of an interesting curve just to kind of show the group. I think, there have been a lot of advancements in treating patients with sickle cell disease. If you look back in 1979, there was a peak of death for really young patients, less than 5 years of age. And then that kind of peak again tended to happen in the 20s to 30 age group. And with a lot of the disease modifying treatments we have now, we do see that in 2016, at least, the age of death for sickle cell patients is, kind of shifted over into that 40, 50 range. But again, that's still quite early compared to the general population. So I think you've had talks about this before. So I'm just going to briefly touch on some of the disease modifying therapies that we see that are being currently used in sickle cell disease, and then I'm going to focus on transplant, which is what you want to hear about from me. But I think it's important to note that, there's not a lot of disease modifying therapies out there for sickle cell patients. The most common ones that you've probably all heard of and aware of are hydroxyurea. And that's been shown to have really helped patients decrease the risk or the number of pain crises they have a year. It was first approved in adult patients, and now is, since about 2012, has been utilized in pediatric patients as well. And we do tend to see that it has a better effect in the young patient population, and that ability to stop or prevent multiple pain crises does tend to wane as a patient gets older. So that's something to kind of keep in mind. And then newer, there's been several studies that have looked at the use of chronic blood transfusions to help decrease the risks associated with sickle cell disease, specifically stroke. And that has been shown to be a benefit in pediatric patients and even young adults. And then there's newer agents that I think Dr. Ferriton came and gave you kind of a talk about these, like glutamine and the Voxetor. and crizotinib. So I won't go into detail about those, but I do want to just say that from a transplant standpoint, a lot of these therapies actually are beneficial even before coming to transplant. And the reason for that is we've seen that in patients who come in previously treated with hydroxyurea or with some of the newer agents, that they tend to hopefully have less organ damage because the amount of crises they're having and the effect that the sickling has on their body can be a little bit less. And that will eventually help them decrease the risks associated with transplant. So any questions so far that I think this is all stuff you already knew, but just wanted to give a little background. Okay. So really, when we talk about transplant, we're really trying to find a curative approach to sickle cell disease. All the therapies I listed before really just help you manage your sickle cell, but they don't correct the problem. And so as of right now, the only way to correct sickle cell disease is either through transplant or through gene therapy. And our goal is always to improve quality of life. We're trying to restore the erythropoiesis, so the red cell production, so that you can make normal red cells. And ultimately, what we want to do is stop any of that organ damage that happens as a result of the sickling of the red cells. And we've seen this in kids, actually, that if they get transplanted kind of early in age, you can actually kind of better correct their spleen function, because that over time obviously can go away. But we have seen in pediatric patients who go through transplant at a young age, you can actually recover some of that splenic function. And then obviously we want to prevent any more damage from happening, but I do have to say that when a patient comes to us with prior organ damage, transplant won't reverse anything that has already occurred. And if anything, sometimes because of the way that transplant is administered or gene therapy, we can actually make some of that organ toxicity a little bit worse before it kind of halts. And so one key example is patients who come in with a stroke prior to transplant. So I guess, you know, when we talk about transplant and kind of who is eligible, really the first step is trying to see, is there a donor available? And so when I get referred a patient, I automatically ask for the patient with sickle cell disease to get HLA typing. And these are little markers that you have on your cells that help kind of the body's immune system recognize different proteins and viruses and other particles within the body. And the reason why that's important is because when we do a bone marrow transplant, you're giving cells from somebody else. And we need to make sure that these markers that are really important in your immune system are as well matched as possible. And so the first donors that we try to look for are sibling donors. And so we will ask if there are fully matched siblings of a patient that they also get HLA typed. And I can tell you that the likelihood of finding a sibling that's fully matched is 25%. So that's a 1 in 4 chance that your other sibling will be HLA matched. In most cases, that's not the case, unfortunately. And so we do then have to talk about, are there other donor options that we could potentially use? And that's what we refer to as alternative donors. And these donors are either people unrelated to you, so you know, a generous donor who is willing to donate their stem cells. It could be umbilical cord blood that is collected when a baby is born. Again, that's also someone who's not related to you. And then more recently, we've been using what we call haploidentical or half-matched donors from your family. And so if you look at this little chart, the diagram I kind of showed over here, these letters kind of just reflect your HLA markers. And so you can see that you get one from, so this, say this is the patient with sickle cell disease. They got that red group of HLA from dad, and then they got the green one from mom. And if they had a sibling, this sibling would be matched, okay? But as you can see that the other 3 siblings are not matched. But the sibling in the middle here would be considered a half match because they have one of that red, combination of HLA markers. Same thing with dad being half matched and mom being half matched. And so I think it's important to note that because over the last, I would say 10 years, the transplant doctors and community are really trying to work hard on how to utilize half-matched or alternative donors so that we can offer transplants to more patients. And any questions so far?
Yeah, sorry, I have like 2 questions.
Sure, yeah.
So just to kind of go back a little bit onto the therapies that do treat, which one has been like more effective, like between Viloxator and Crenzolimab? And if these have been introduced early on to the kids who, and what the likelihood that if they're introduced early, what age do they introduce them early to the kids, and how effective have they been, or what have you guys learned from that?
Yeah, so that's a good question. So as of right now, Viloxator and Crenzolimab is not approved in young pediatric patients. It's 16 and older, and so the FDA hasn't approved it in the young group yet. I'm sure they will in the future. We do sometimes utilize Viloxator and Crenzolimab, even though it's not FDA approved in the young folks, but you really have to do that on a compassionate use basis. So it's, from an efficacy standpoint, I can't speak to the pediatric group, okay? What I could talk about is the hydroxyurea, because that we start typically very early in the pediatric patients. We've seen, patients as young as 2 years of age being started on hydroxyurea if they have sickle cell disease that is presenting with a lot of crises, okay? And so we don't preemptively, at this point, we don't preemptively put patients on hydroxyurea or these disease-modifying therapies. It's really based on how severe your sickle cell disease is. And I can say, because even within family members, 2 siblings who have sickle cell disease, they can each manifest symptoms differently. Someone may have more sickle crises than the other sibling. And so it's really based on how frequent their pain episodes are, how many times they're happening a year, and then the severity of them. So in the adult patients, I think because Viloxator and Crenzolimab really just got approved in 2019, it hasn't been FDA approved all that long. It's 2 years. And so I think we'll see now as we start using these drugs a little bit more, what their impact is if we introduce them in younger adults earlier. But right now, it's if you failed hydroxyurea and for whatever reason, chronic transfusions is not an option, then we've been using some of these therapies. And I know some of the adult hematologists are preferring to use these agents before starting chronic transfusions. And so we'll get a better sense of that over time.
Okay, cool. Thank you.
Yeah. Any other questions? Okay. So, when I see patients in the clinic and they come to me, it's really hard to explain the bone marrow transplant process to them or stem cell transplant to them. Because it's a lot of information that I provide at one time. And so I liked this kind of timeline to break down what stem cell transplant entails and kind of how long the process really runs over, as well as what each stage involves and what the risks are within each stage. So I'll start at the start here. When I get referred a patient, one of the things that I have to do is, 1, see if there's a donor available for them. And then 2, see, is their disease severe enough to undergo stem cell transplant? And I know that sounds, like we're cherry picking, but we're really not trying to do that. What we're trying to do is weigh the risks and benefits. And I'm going to show in a few slides what the risks are with transplant. So there are some patients, for example, who have milder sickle cell disease manifestations, and they don't have a good donor available to them. And in that case, I would say, until things get better, perhaps with gene therapy or other ways of doing transplant, we should try disease modifying drugs instead. Okay. And then there are other times that I get patients where they are relatively milder sickle cell disease, but they have a matched sibling. And I will offer them transplant up front because the outcomes with having a matched sibling donor are really good. And so it's about a balancing act between how severe their disease is, as well as what are their donor options, and what do I think the risks are going to be with the transplant. So once we decide, yes, the patient is eligible to go forward with transplant, there's this period of time that we call workup, and it can last anywhere from 1 to 3 months, where the patient undergoes a bunch of evaluations for us to get a good assessment of what their organ function looks like, what their prior infection exposure has been, and really just trying to see if there's things that we can do to optimize the transplant before they undergo stem cell transplant.
Dr. Mallhi?
Yes.
One question back on the workup, the severity of disease question. So it used to be, can you hear me?
Yes, I can. Yeah.
Okay, so it used to be, when you said severity of disease, it was also about like, had you been in the hospital, had you had acute chest, like, are those still parameters before someone can consider bone marrow?
Yes, yeah, and I have a slide a little later just showing what our criteria are right now. So I can show that to you now if you would like to see it now. It's maybe somewhere here. So when we talk about indications for transplant, this is kind of the checklist. So you don't have to have all of these events, but you have to have had at least one of these kind of criteria to be considered for transplant. And you can see that I didn't list it underneath matched sibling. The reason why I didn't list these criteria under matched sibling is because I'll show a little bit later on that age is also very important in who does well with transplant. And so if you can take parameters like a young age and a matched sibling donor together, I may consider offering transplant to the family, even if they don't have all these other criteria that we need for, say, an unrelated donor transplant or a half-matched donor transplant. And that becomes a discussion with the family about what the risks and benefits of both are and what their goals of care are, or, in terms of quality of life for their child. It's a little bit difficult to have that. I wouldn't say it's difficult. I think when the patient is older, say a young adult or an older adult, that then becomes a little bit trickier just because there is slightly decreased benefit in patients who are older. And so then that really becomes on how severe their disease is. But when we talk about, say, a transplant from someone who's not related to you, so an unrelated donor, or a half-matched donor, a haplo donor, what we look for are, has the patient had 3 or more pain crises within 2 years, despite having supportive care? So any of those, hydroxyurea, Veloxator, blood transfusions, etc. Have they had 2 or more acute chest syndrome episodes within 2 years? Anyone who has had a stroke is, in my books, considered eligible for a transplant, provided we can try to find a good donor for them. And I'll talk about a little bit of a caveat with gene therapy for that. But there are also, and then, so those are the main criteria that most people are pretty typical, pretty used to hearing about. We do start looking at end organ damage as a result of sickle cell disease too. So over time, when you've had multiple acute chests, and just, because of the way the sickling affects the oxygenation in your lungs, patients with sickle cell disease can develop what we call sickle lung disease, so decreased pulmonary function. That is also an indication for transplant. Similarly, if you're starting to show evidence of kidney disease, so if your GFR, which is how your body clears, essentially fluid within your body, is about 50% less than what we would predict for your age, then that's an indication. Anyone who is needing more than 8 red cell transfusions per year is also considered for transplant. And then more importantly, anyone who has a echocardiogram that shows the velocity through one of their valves is really high. An echo, sorry, it's an ultrasound of the heart so that you can see what the function is. If we're starting to see that the velocity is super high, that is indicative that there may be some cardiac dysfunction in the future. So that's also an indication for transplant. That's a good question, Foxy.
Is there an age limit for these therapies or transplant?
There's no age limit. We'll just jump ahead then. I'll show you. I would say that there's definitely not an age limit. It really is more about what therapies are available within that age group. Okay. And so, for example, in pediatric patients, the outcomes are significantly better than in adult patients. And that's because if you just think about children in general, this happens even with not sickle cell disease, like other diseases that go through transplant. A lot of times the organ damage is less, they're young, healthy individuals for the most part. Even if they have sickle cell disease, it hasn't been years of effects on their organs. And so that makes the transplant a little bit smoother. The other thing that we see is that even if a child does tend to have some side effects related to the transplant, for example, the chemotherapy or infections, they tend to recover a little bit faster. And then they also are at lower risk of developing graft versus host disease, which I'll kind of explain in a little bit. And so all of these factors play into how well a patient does. And it's been shown in multiple analyses that the younger you are, the better you do, okay? And so historically, the cutoff has been 16 for good outcomes, okay? Doesn't mean you can't get a transplant if you're over 16 years of age. There was this nice study done looking at 1,000 individuals with sickle cell disease who went through transplant. And you can see they had someone as young as 5 months of age, 4 months of age, and then someone as old as 54 that went through transplant. But what they did see is that if you were less than 16, 95% of those patients survived the transplant. But if you were over 16, 81% survived. So that's 19% of patients over 16 who did not survive the transplant itself, okay? Similarly, when we look even within children, even within the pediatric group, we actually see that patients less than 10 do better than patients 10 to 21, okay? There are newer therapies that are being utilized for young adults and older adults. And a lot of these therapies are showing promising outcomes. And so that age limit of how old you can be when you go through transplant is starting to get higher and higher. But I would say on average, 50 is kind of where, we're starting to get a little bit worried about the toxicities of transplant in that patient group. So that's a good question.
Thank you.
Yeah. Any other questions so far?
Yeah, I had a quick question.
Mhm.
In the selection part, why is it that in order to be eligible, you have to be young, but well, maybe not necessarily young, but like you have to have all these acute symptoms like to be severe
Yeah.
in order to be eligible, right?
Mhm.
However, the whole point of the transplant, I think from my understanding, is to stop the progress
Mhm.
of that of those you know, of those sick of those symptoms, right, of the
Right.
disease. So if you have a patient who is already severe, has all these issues that keep on coming up, but then they're not eligible, and the whole point of the transplant is to try to slow that down. I feel like there's a contradiction there that's kind of confusing for some of us.
Yeah.
Is there a way you could like clear that up a little bit?
Sure. Yeah. I can actually show you. There are some slides I can talk about why that is a risk, but what I wanted to show you was this. So when we, as I mentioned, when you have a matched sibling donor, okay, the risks associated with that transplant are much less than if you have a half-matched donor or an unrelated donor or a mismatched unrelated donor, okay? And I'll go back and show why that is, because there's certain risks with the transplant process itself that puts you at risk for dying because of the transplant, okay? So it is, I agree with you, the younger you are and the healthier your organs are when you come to transplant, the better you will do with transplant, okay? But there is inherently a potential risk of dying from the transplant itself. And so when we look at sickle cell disease, you know, it's a terrible disease that causes lots of pain and lots of morbidity over time, but it won't necessarily cause death in the immediate period other than, say, a stroke in a young child, for example, okay? As you get older, that risk becomes higher, okay? So we do know that. And so in a kind of crude way of saying this, I have to weigh the risk of, is your likelihood of dying from sickle cell disease higher than your risk of dying from transplant? Okay, so
Oh, okay.
it's about balancing out, will you survive the transplant and be cured of sickle cell disease, or will you unfortunately pass away because there's all these risk factors from the transplant itself? Okay, and then I have to take into consideration your sickle cell disease as well. Okay, so when I again, I'm a pediatrician, so I have a little bit of a biased take on transplant because I like to offer it to as many patients as I can, because I want, like you said, to try to prevent that organ damage long term. I want to ensure good quality of life. And most of the people I see are healthy enough where if they have a good donor option, we can offer it, okay? But the risks are more so when you're an adult. And those criteria become a lot stricter for the adult population because their risks from dying from transplant are a lot higher, okay? So if you look at this chart that I kind of pointed out here, this top line here lists what we call event-free survival. So what is the likelihood that you will survive the transplant, be cured of your sickle cell disease, and not die from a complication related to the transplant itself, okay? So in a sibling, you're likely, if you have a sibling transplant, it's 89% of patients that go through a sibling transplant will be cured of their sickle cell disease and alive and well, okay? So there's still, obviously 11% of patients who don't do well. When we look at the half-match donors, it drops down to 50%, okay? Which is that's a significant drop in trying to have what we call a successful transplant, okay? And similarly, when we look at an unrelated donor, it's down to 70%, and then if it's a mismatched donor, it's about 63, okay? What I should point out that's a little bit different is that in sickle cell patients, we can usually get you through the transplant and help you survive the transplant. Okay, that's what this number here, the overall survival means, right? How many people go through the transplant and they're alive. So if you look at the siblings, it's 96%. You can survive the transplant if you have a matched sibling, but sometimes the transplant doesn't work. And that's why you have that difference between the 96 and the 89, okay? And so it's unfortunately a juggling act. And I think as our therapies get better and we're able to do transplant and or gene therapy in a safer manner, then those criteria that we had before are going to get less and less, if that makes sense. So then we'll be able to take patients younger who don't have all those manifestations and really try to cure it before they even have significant organ damage. But we're just not there yet. It's a really good question. I would say that it's improving significantly over the last 15 years, but we've still got a lot of work to do. Okay.
That's good. Thank you.
Any other questions I can answer so far? Okay. So let me just kind of explain the process, because maybe, sorry, did someone else have a question? I can't tell. I can't see the chat box, Foxy, so just let me know if there's any questions. But so when we talk about transplant, once I start explaining some of what it entails, I think you'll understand the risks a little bit better as well. The workup we've kind of gone through, we just want to make sure that the patient is nice and healthy enough as possible to tolerate what we're going to put them through in the next about a year, okay, after the transplant. You will need a central line inserted for the transplant. It kind of goes, it's like a more permanent IV that kind of goes in through the chest here. And that allows us to be able to administer all the medications and things that we need to give you during that period of time. And when I meet with my families, I really do tell them that the transplant process is kind of broken up into these steps, but overall it takes about a year, okay? So from the start of starting your workup and going through the process of being in the hospital, getting out of the hospital, and really recovering, it can take up to a year, and sometimes even longer, depending on if you have some complications during that time. The next stage that we refer to as the prep stage, and that's about 1 or 2 weeks before the transplant happens. And what happens during that time is you get admitted to the hospital, and this is where you receive the conditioning or the chemotherapy medications. Now, unfortunately, there is no way for us to do a stem cell transplant or gene therapy without giving chemotherapy. It is the only way that we currently have to eliminate the stem cells in your body, in the patient's body, that make these abnormal hemoglobins, okay? And so once we can eradicate those stem cells, then we can give new stem cells from a donor, or if they're modified by gene therapy, and those can then start to grow and make normal hemoglobin, okay? And so the intensity of the chemotherapy has been ranging a lot over the last several years, and I'll show that with you as well. But historically in sickle cell patients, we have to give what we call the myeloablative or really high intensity chemotherapy. And that's because sickle cell disease has a lot of inflammation associated with the disease as well. Not only do you have problems with the sickling, but your body is more reactive. Like you can make more antibodies, you can make all these things that can impact your immune system. And so it is best to try to eliminate as much of that as possible so that we can really ensure that the new stem cells from the donor have the best opportunity to grow, okay? So typically that, I would say that the chemotherapy typically goes over anywhere from 5 to up to 12 days. It really depends on what donor you're receiving, stem cells you're receiving, and what your what that workup showed in terms of your body's tolerability. And so the combination of chemotherapy varies a little bit, but it's on average anywhere from 5 to 10 days of medications that you're getting administered, and they're given through the central line, and you're in the hospital during this time. And then we have what we call day 0, and that's the day your stem cells are infused. And so these stem cells are collected from the donor. We prefer that the stem cells be collected directly from the bone marrow. And typically, if you're a sibling who's donating for your family member, for your sibling, we will do a small procedure where you are sedated. You do go to the operating room, and we insert a needle into the back of your hip bone to collect stem cells from there. And the reason why we do that is the bone marrow has a large number of stem cells in it. And it also has less T cells in it, which are responsible for causing graft versus host disease. And so we want to try to decrease that risk as much as possible. There are other places you can get stem cells from. You can actually get your stem cells directly from your peripheral blood, from your arm. And so sometimes we do collect that from donors, but there's a higher risk of graft versus host disease if you do that method. So we try to avoid it. And as I mentioned before, if you're using umbilical cord blood, then the stem cell collected from the baby's cord blood at time of birth. Okay. And then once the stem cells are infused, it actually comes, it's like a blood transfusion. It comes in a bag. It's kind of anticlimactic. So, it comes in a bag, looks like blood, and then it's infused through your central line. The infusion takes usually about the same amount of time that a blood transfusion does, about anywhere from 2 to 4 hours. And then it's a waiting period, okay? Then you're waiting approximately 2 to 3 weeks for those stem cells to start growing. So this is what we refer to the engraftment period here. And depending on who you get the stem cells from, the duration of time that you have to wait can vary a little bit. So, but on average, I would say it's about 2 to 3 weeks. So during this time, what you're doing is your body is really starting to feel the effects of the chemotherapy we gave you, okay? And so all the side effects and risks that come with the chemotherapy, including, need for blood transfusions and platelet transfusions, that happens during that time. The nausea, vomiting, diarrhea that you can see with chemotherapy, you experience that during that time. There, you can also develop sores in your mouth. I don't know if anyone's ever had like an aphthous ulcer, one of those, white ulcers that you can get kind of in your mouth. You can develop that all throughout the mouth, and it can be quite painful. And then because of the nausea and the pain in your mouth, you may not want to eat or drink anything. And so a lot of times during the hospital stay, you're getting nutritional support, either through an NG tube that goes through your nose into your stomach, or through TPN, which is a nutrition that comes in IV form, okay? And then also, while we're waiting for these new stem cells to kind of grow, we've eradicated your immune system. We're really taking away the stem cells and your immune system with the chemotherapy. So you're at a very high risk for developing infections. And it's not uncommon that people get infections during that time. And sometimes those infections can be life-threatening. And so that's why it's really important to be in the hospital throughout that process. The other thing that we see, unfortunately, whenever we give medications, regardless of what they are, they have side effects. And most of the medications are either metabolized through your liver or they're metabolized through your kidneys. And so in transplant, we see that certain chemotherapy drugs, as well as some of the medications we're giving you to try to help prevent some of the infections and side effects that you're experiencing, can cause damage to the liver, and they can cause damage to the kidneys as well. And so in patients with sickle cell disease, if you come in with kidney disease before transplant, that makes it more likely that you're going to have problems with those medications that are metabolized through your kidneys. And it can sometimes cause your kidneys to not function very well. And in very rare cases, we do sometimes see that patients end up on dialysis during that time, okay? But it's a short period, really in the process of trying to help your body recover. The other thing that we see pretty commonly, or actually I shouldn't say commonly, it's just a very high risk in sickle cell patients, is a problem that occurs in the liver called veno-occlusive disease, or VOD. And it is a result of the chemotherapy and medications causing little clots in the liver. And when this happens, it causes the liver to get very angry, not behave properly, and you can see evidence of liver damage. Now, the reason why it's a risk in sickle cell patients is that if you've been getting chronic transfusions, okay, for a long time prior to your transplant, the chronic transfusions have a lot of iron in them, and the iron can deposit into your liver, okay? And that can cause scarring or damage to your liver. And so part of your workup when we see you in the earlier parts is to assess your liver to see how much iron there is in your liver. And the lower the iron is in the liver, the better you will do. But the less likely it will that you'll have some liver damage from the chemotherapy. And I'll go over this a little bit later too, but the drugs that we use, the chemotherapy drugs that we use, some of them are very specific for the liver. And so if you have a lot of iron in your liver before the transplant, that's going to make me change the chemotherapy drugs I can give you. Okay, so these are kind of the things that go into the process of deciding who can get a transplant and how can I do it safely. Okay, but once you've and I just want to say that the risk of kidney and liver damage is still quite rare. Okay, I want you to be informed about the process so you understand why sometimes we're a little hesitant, but in the grand scheme of the number of patients that get transplanted for sickle cell disease, the likelihood of kidney and or liver damage is less than 15%. Okay, so it's still a risk, but it's not high. Okay, I can tell you, for example, you will have nausea and vomiting and diarrhea. All patients get that. That's very common. Okay. You will be at risk for infections. That's very, very common. Almost 100% of patients get some sort of infection during the transplant, but we can treat those. We have medications to treat them. The toxicities to the organs are less, but it is something that we have to look at when we decide who can come to transplant and who can't come to transplant. Thank you for sharing. And I think I agree. When I meet with my families, I oftentimes meet with them multiple times because the first time I try to present all this information to them, it is scary. And I know that, but I also want families to be aware as much as possible of what they're going to get themselves into, because I think sometimes when I get referrals, they're like, oh, transplant's an easy process and it can fix me. And I'm like, take a few steps back. There are a lot of risks, right? Yes, the end goal is great. The sickle cell is cured. But if I'm going to end up giving all these other problems as we go along, does that really improve your quality of life? And so that's where the doctors have a hard time trying to balance that out with families and also trying to relay that information to families. I like to be as transparent as possible because I want our families to be educated and advocate for themselves and understand what they're getting themselves into. But I also do want to provide them hope. So I'm sorry if this is sounding too scary, but I really, think that this is a treatment option, and for many patients, if they have good donor options. As gene therapy comes along and that starts to get better developed, that is also going to be another option for families And as John mentioned, we're doing haplo or half match transplants now as well. And historically, they didn't do very well in the past because of the risk for graft versus host disease or GVHD. But we found in the last 10 years, newer ways to try to decrease those risks. And so we try on our end to work on these toxicities that we know can happen and how can we improve them. And you know, these toxicities are experienced through all patients who go through transplant. You know, for other diseases like leukemia, for thalassemia, for other things, the process that I describe here is very similar for everybody, okay? But what's unique to sickle cell disease is that oftentimes, as John kind of alluded to, is you come in with a lot of stuff too. And so then it makes that risk a little bit higher. And we as physicians need to educate families properly about those risks. And also, you know, say when it's a good idea to go to transplant and when it's not a good idea. And so I hope I'm kind of relaying that information a little bit to everyone today.
And to be clear that this doesn't undo some of the damage that has been done earlier. And I think that that's kind of a misnomer as well.
Right, yeah, exactly. So anything that's already happened prior to the transplant, stem cell transplant does not correct it. If anything, it can make it a little bit worse. So, you know, like as John was saying, for example, sickle cell patients are at risk for AVN even without going through transplant. But then you go through a bone marrow transplant, and if you develop graft versus host disease, and I have to give you steroids because that's the treatment for graft versus host disease, the steroids make the AVN worse. And so sometimes when I have patients who come in with sickle cell disease who have already got avascular necrosis, I tell them up front that your avascular necrosis is likely going to get worse with the transplant, and you may or may not need a, you know, joint replacement at some point in the future, depending on how severe it is. But if a patient comes to me who doesn't have AVN, then that risk is lower, you know. And so I try really hard to counsel the families, kind of specific to each patient. This is obviously kind of a general discussion for everyone to kind of hear, but that's a good point, Ken. Yes, we can't fix the problems that have already occurred. We can only try to potentially help them from worsening over time. And I do want to say, like John mentioned, that caregiver aspect is a big part of transplant and oftentimes is one of the biggest limitations of patients coming to transplant. We do require that a caregiver be available for the patient. So even if it's an adult patient, they still need to have a caregiver there for them throughout that transplant process. And in pediatric patients, we tell our families that that caregiver role is for a year, because that's really how long it takes for you to recover, administering medications, etc. You know, making sure that if you're sick, you get to the hospital, all those things. And then for the adult patients, the caregiver is really important within the first 6 months. After that, the adults are usually able to get themselves to appointments and to hospitals and things like that. So the burden is a little bit less when you're an adult. But I think that's hard sometimes when I meet with families and I say, you know, one parent can't work for a year while their kid goes through transplant, and it's a big shock. And so, you know, I like to prepare and inform families of that requirement as well through the transplant process.
How about the finance issue? Because you did mention, you know, like parents, one of them might have to stop working to take care of the other.
Yeah.
Then what resources are available for those who are concerned about finances to still make ends meet, but also take care of the kids?
Yeah,
and what
so
is
that's
this going to cost?
Exactly. That's a good question, John. So that is unfortunately a huge barrier. Unlike cancer, where there are lots of fundraising groups and support groups and things out there that provide money to the hospitals to help families going through, they can apply for grants and things like that. In sickle cell disease, that is less. We don't have as much funding options for families of patients with sickle cell disease going through transplant. We are trying to find more funding avenues. I know at Seattle Children's, there's a compassionate care fund that if families need help with medications and other things like that, they can help, cover those costs in addition to whatever your insurance or Medicaid offers. We make sure that as part of that workup process that families do, you meet with one of our social workers right off the bat, and they help families, apply for any grants or any kind of work-related time off forms and things that we can do so that the families can get some support there. And then more recently, we're trying to partner with some groups out there that are actually, like the Luke Strong Foundation, for example. They're really trying to help provide grants and resources for families of sickle cell patients going through transplant. And so we're hoping that the SCCA will partner with them this year. And so that also gives some funding opportunities for families. So there's still a lot of work to be done there, John, and I'm trying to work on it. I think more awareness of sickle cell disease and the demands that transplant has on families, getting it out there is where we're going to be able to help support the families the most. Sometimes my job is so focused on the medical part of it, but I really do try to make sure that the family is supported as much as possible. And sometimes we're not aware of resources out there as well. We try really hard to keep up with all of it, but it's always changing. And so when I heard about this task force, I was really excited to be invited to talk, and just knowing that it existed, I didn't know up until, I've been in Seattle for 5 years now, and I just heard about this task force last year. And similarly, the other, like John, I know has seen a couple of my patients as well. But I think it's important when there are community involvement as a group that we try. My job also is to inform families of like who to get into contact with and who to talk to. And so if this is something that is, as a group, you guys are going to continue to work on, I will also, provide resources to families as they come to me. And I would say to Mamie's point too, I think, so there are obviously some barriers between referrals for transplant from a hematologist that you've kind of grown up with and they've taken care of you for such a long time or early in the disease, and then kind of having to meet with, for example, me, who doesn't know your child or doesn't know you, and who's going through sickle cell, and then telling you about these therapies. And I think what I've always tried to advocate for our sickle cell patients is information doesn't hurt. Okay. And just even coming to chat with me or some of the transplant doctors who do sickle cell disease to get this information, trying to find it online can sometimes be a little bit tasking, but talking to someone directly about it when it's directed to your child is really informative. And if you feel like there's families out there that are hitting barriers where their hematologists aren't referring, you can make a self-referral, okay? And I just want to advocate for everybody as well that information doesn't hurt. If anything, it just helps you grow. And I can say that I think over time, some of the hematologists, just like I'm doing like an education session with you, we meet with hematologists throughout Seattle and through Washington and do the same education with them so that they understand how things have changed in transplant and what we can offer patients with sickle cell and how we can make it better for them. And I think the referrals are changing now. Okay, I think hematologists are more open to having families come by and chat with me or other doctors to learn this information at least. And then the decision-making process after that, is really up to the family and what their goals are. But that was a really key point that you pointed out there. So thank you for bringing that up. All right, so Foxy, I don't know if how we're doing on time.
So I already have the feeling, Dr. Marlowe, that you're going to have to come back
Okay.
uh,
No problem.
because there's so much more that we need to understand. So you
Yeah.
tell me, we're at 118. We're supposed to finish around 1:30. But I don't know if I'm assuming, because we've done the education events long enough, that you probably didn't get through all your slide deck yet, right?
No.
So it's up to you. We can totally continue until 1:30. We can pause here and ask questions, and then we can also do a follow-up if that's, I think that's going to be needed. Even just hearing
Yeah,
what made
totally.
people say.
Happy to come back and do some more. Why don't we open it up for questions? So I want to make sure that I answer anything that I can answer for the folks on the call.
I have a question. I'm not sure. Can you hear me okay?
Yes, I can. Yeah.
Thank you for the presentation, doctor, and thank you everyone who's spoken up so clearly and informatively and passionately. I don't know, maybe I don't have a question. It's just I guess just a feeling or a sentiment. Gosh, she's loud. I just feel frustrated because I feel like with our son, we're tossing around the idea of doing this for him. He's been in severe pain for over 4 years now that has really been debilitating. And I feel like we're in a situation where he's too healthy, and I think the option that I'm concerned is he's just being given a lot of drugs and not being able to really use this as an option to kind of shift his trajectory in life. And so I don't know, I just feel like he's going to be kind of on this trajectory of taking more medicine because he's too healthy. And then we get to a point where, oh, now he's worse, so let's do the transplant. So I don't know, maybe there's not a question in that, but just a frustration.
Yeah, and I totally understand the frustration. I've met with many family members before who have that same frustration. You know, again, I think this John kind of brought this up a little earlier as well. It sadly at this point in time really depends on the donor available, that you have. So I have taken patients with matched siblings who don't have severe disease to transplant. Okay, so if they have sickle cell disease, and even if they haven't had a lot of pain crises and they're young and they have a sibling, we will offer transplant. And as long as the family feels like they've been counseled about all the risks and benefits and they want to move forward, we've moved forward. Okay, so I've taken a young 4-year-old who maybe had 1 or 2 priapisms and otherwise was doing quite well from a sickle cell disease standpoint, but the family was really interested in transplant. They had a sibling donor and we moved forward and that patient did great. But at the same time, I've had patients that come see me where, their sickle cell is bad. Like it is infecting their daily life and they're having a lot of crises, and I don't have a good donor source for them at all. Okay, and that frustrates me because I want to be able to offer these parents and these patients some options for therapy, but we just don't have it yet. And I can say that the field is evolving quickly. Okay, and we didn't get to touch on gene therapy today, but really that's one of the other things that's coming down the pipeline that might offer a lot more opportunity to patients with sickle cell disease, especially for those who don't have sibling donors. Okay, there's also a lot of notion that these transplant from someone who's not related to you, like a fully matched unrelated donor or a half match haplo donor transplant is a bad idea. And if you had asked me 10 years ago, I would have said, yes, it's a bad idea. Okay, but it has changed a lot because we've managed to find ways to use those donors and still have very low risks. And I think we can still continue to learn more about that. And in those cases, we are a little bit stricter about who can come to transplant because it's not, we just don't have that long time period of data to show, yes, it's actually quite safe, And so if your disease is milder, then I'm not going to recommend a half match or haplo transplant if you've got mild disease, because we still need to understand does the risk outweigh the benefit, right? Or does the benefit outweigh the risk? But if you ask me in 5 years, I might have a lot more information about that, and then the scale changes, you know? And I think, like I said before, if there's, you know, if you're toying around with it, or you just want information or discuss, you know, to kind of really have someone look through your child or your history, your medical history, look at what your options are, and then tell you upfront, is this something we can offer you? That is, you know, you're more than welcome to self-refer for a consult with a transplant doctor, because that's what we will do, right? We will look at your individual case, look at your donor choices, look at your body health, and then weigh your risks and benefits, and then, you know, your risks and pros and cons essentially, and give those to you to discuss. And I hate to say it, I've had families where I've told them, no, we can't go forward with transplant because I don't have good therapies for you. And it breaks my heart that I have to do that. But I am hopeful that in a few years that won't be the case, okay? But there are some groups that we should definitely be advocating for them to at least meet with us and get that information. And this is a good stepping stone, and I'm happy to come back and chat more about that as well with the group.
Yeah, so Dr. Mallhi, thank you, because I do, and what came out in this is definitely this situation on awareness of, I don't think anyone knew that they can self-refer. That's new information. And love to hear a little bit what does that look like, just calling you and saying that, you know, but I think that's one thing just to hit on. I do think in the peds world, you don't get the sense that this kind of level of education is a constant thing. You know, sorry for everybody on this call, our son does have a sibling match. Everyone on our team has known that for a long time, but it's never been something that there's more education around, hasn't came back to it. So that just tells me that there needs to be more education, probably on the hematologist side, that they make sure that they are encouraging families, because, and the reason I said that is because I was looking at your data and it said to 16, like it's better if the kids have a sibling match to really consider this when they're younger. And I think it would be really helpful so families can make plans around when and how they might do it, right? Because of that financial burden or the caregiver situation, they can say, okay, we can plan this out to do in 2 years from now or whatever. So just when you're working with hematologists, I think one feedback is on our end, we're not hearing that education at all. And so then we have to self-refer, which is kind of crazy to me, because we're also managing a lot in our plates and don't know sometimes that that's where we have to go. Right. But since that is where we are, I'd love to hear, what does self-refer mean? That just means call y'all?
Yeah, so actually, if you go on the SCCA website, and I can send you the link, there's a thing there that says bone marrow transplant consult, and you can put in your information and it'll go through the SCCA transplant coordinators, and you can just say self-refer. So the docs refer that way, and you can refer that way as well. And then what they'll do is, usually most of the sickle cell consults come to me, but you will then kind of get like a notification of when you can meet with me, and I can review things with you. And I think, Foxy, I do, you know, I want to give the hematologists some credit, because they also don't understand transplant to the same degree that I do. They are focused and specialized in sickle cell disease, but not necessarily this whole other field, which kind of is a mind of its own, and even though we kind of all train, like I'm technically a hematologist-oncologist trained as well, but I specialized in transplant. And then even within that, I specialized in sickle cell disease. And so a lot of these nuances they don't understand. And I think what I've been trying to do with a lot of our hematologists, more so with the pediatrics, but I am also reaching out to the adult hematologists too, is this this notion of education, like giving them education as well about the process, but also making it quite clear that if they don't have the time or understanding or bandwidth to talk about these things with the family, then that's what that's what the transplant doctors are here to do, is to talk about this with the families. And so, I'm constantly saying, if you want to refer this patient for a consult, I would be happy to meet with them, because I want to provide that education for the families. I think doing, like you said, like this session is a great way to get that information out. And maybe it's something that needs to be done on an annual basis just to keep things up in the loop and up to date. I also will say that I oftentimes meet with families 2 or 3 times before they even go to transplant. So just because, you're right, sometimes the timing is not right when you meet with me the first time, but it may be something that you consider a year or 2 later. And it's constant education. And like I said, constant education doesn't hurt, right? It can only help. Within my bandwidth, I try to do what I can do. So, yeah. Any other questions?
Do you think that the field is changing that much within a year, within years?
It usually within 2 or 3 years, there's quite a big update in things that happen, because we learn, like, for example, we had a haplo or half-match sickle cell transplant protocol open at our center for the last 2 years. And so people have been enrolling on that research study, getting transplants with haplo donors. And, obviously through a lot of education, the families were willing to trust in that process to be enrolled on the study. And then we should have the actual results and analysis of those within the next year and a half, right? So if you meet with me, if you meet with me right now, I can tell you preliminarily what that looks like. And yes, we think it's doing really well. But if you meet with me in 2 years or a year later, I could tell you definitively, this is what we were able to show. And yes, this is a good therapy, or no, it's not, And similarly, I think gene therapy is taking a little bit longer. It advanced quite quickly at the start, but then kind of now is in that process of really validating what they're seeing. And so, but even within 1 or 2 years, things do change. So on most occasions, I would say every 2 years, if you want to break in between and need some time to process the information and something changes, then coming back to discuss with me 2 years later may have different results. And I've also had families where, the child is quite sick from a sickle cell disease standpoint, and they don't have any donors, and we will say, we'll check again. Did someone new come on the registry that we could use? Did something change in terms of donor options or gene therapy that we could now consider? So I would say every 2 years is a good kind of update if you haven't had any luck the first time.
All right, well, it's time to go, y'all. We have been informed today. Thank you so much, Dr. Mallhi. This has been really, really great. Thank you to all who chose to be here. Mamie and John, I know had to leave early. Thank you as well for just sharing your own story. This is just the beginning of conversations. So let's just continue. Dr. Mallhi will reach out and go ahead and schedule another one coming soon, so we can finish those slides, because I'm sure there's more to be understood. And maybe we can even invite our providers in. We have good relationships with our providers, and so I'd love to even welcome them so that we can be learning together. Learned a lot today. Just thank you again, everyone, for coming.
Thank you.
Reminder again that Sickle Cell Day in the Park is next month, August 28th. Make sure you register through the Camp Corey website. It's in the chat way up above, the first link sent. And then if you have direct questions for Dr. Mallhi, can they reach out to you directly? I can pass on your email. Is that okay?
Yeah.
Okay, I can, if you want to text me or email the task force website or email, please do. If you want direct contact with Dr. Mallhi, we can make that happen. But again, thank you so much for the day. It's a beautiful day if you're in Washington, so I hope you get to get out there and enjoy it. If you're from somewhere else joining us, thank you so much, and we'll see you next month.
Everyone.
Thank you, everybody.
Thank you.
Thanks. Take care.
Thank you.
Thanks.